Those people were trying to kill me. These are the words that Dr. Susie Moore said while she was in agonizing pain, begging for doctors to take her symptoms of breathing seriously. Those people were trying to kill me. These are the words that Dr. Susie. She wanted to be seen as human. She wanted doctors to have compassion and to care for her. But instead, she was neglected, mistreated, dismissed, ignored, and even yelled at. And unfortunately, she died tragically due to complications of COVID-19. She died alone in the hospital without her son. This is not an event that is unique to that specific hospital, to that specific doctor, or to that specific nurse. It is not specific to the city or even to the state. These stories are happening all the time across the nation. It is a nationwide pandemic directly caused by our medical system. It is embedded in the foundation of clinical research and the practice of medicine. Therefore, we must deconstruct this life-threatening medical institution in order to save Black lives. In order to start this, we must start by spreading awareness when these events occurred. We must empower the Black community with tools to advocate for themselves and to advocate for others. We must recruit allies to speak in rooms where we are not present. And that is the purpose of today's conversation. Today, we'll be talking about the racial disparities in labor and delivery. How can Black women survive during childbirth? So I want to thank all of our panelists for being on the stage and for giving us their words of wisdom, because together we can demand change and we can eliminate racial inequalities. And with that, we will get started. Before we get started, I want to remind you of our disclaimer. This video is not affiliated with any governing institution, hospital, institution, or academic association. Myself and the panelists only represent the opinions of ourselves and not any other entity. The discussion, the information here that will be shared is solely for educational purposes only. It is not medical advice. If you have any health-related concerns based on this discussion, please seek counsel from a licensed provider. We're going to go into the format of today's discussion. It will last approximately 2 hours. Our discussion will be in 3 parts, each lasting about 20 minutes, and we'll have an accompanying Q&A. For the Zoom participants, please comment with your questions in the Zoom chat, and one of my team members, Lillian, will be looking at your questions and fitting them as appropriate into today's conversation. For those of you who are streaming on YouTube, you can write your questions in the YouTube chat. Lillian will also be looking at the YouTube chat as well to pick questions that fit in our conversation. For those people who pre-registered, as soon as you click on the link, you'll be in a waiting room. Edo, another team member, will be letting people in, so please be patient with her as she verifies your registration. Another thing we would like for you to do, as you listen to today's conversation, if there's any comments by the panelists that resonate with you, please comment on social media. You can comment using the hashtag Black Mothers Matter. With that, I'd like to welcome our panelists. Our panelists were hand-selected because of their expertise, their advocacy, and their experience for doing this work. I will now allow each of the panelists to introduce themselves.
Good morning. My name is Dr. Dawne Collier. I am a board-certified Chicago-based obstetrician gynecologist of over 17 years. And my mission is to empower women and young girls with pertinent medical information that will that information usually focuses on reproductive health that will optimize their physical and mental health, because I truly believe once we know more, we can do better for ourselves. Thank you.
Thank you. Next panelist, please. The next panelist is Dr. Dixon.
All right. Hi, good afternoon, everyone. I'm Dr. Kamilah Dixon. I'm also Ohio. I am an academic generalist. I'm also in a community program with the aim of decreasing the infant mortality rate in the city. My academic interests include racial and ethnic disparities in care, and as Dr. Collier said, empowering our patients to be able to live their best lives.
Thank you. Next, we have Dr. Nelson.
Hi, good morning, everyone. My name is Dr. LaTasha Nelson. I'm an associate professor of obstetrics and gynecology at Northwestern with the subspecialty in maternal-fetal or high-risk obstetrics. My areas of interest include health equity. I'm the chief director of the Health Equities Clinical Scholars Program, and I'm also involved in help with ensuring safety of immigrants, specifically brown immigrants who are housed in detention centers. And I'm involved in a couple of legal cases dealing with those type things. And I guess my primary goal is just to make sure that we understand the importance of advocating for ourselves and demanding the health care that we deserve.
Thank you. Next, we have Dr. Sutton. Dr. Sutton? I'm going to.
Okay. All right, thank you. Yes, it said, sorry about that. It said the host had me muted. Good morning, good afternoon, everyone. My name is Dr. Madeline Sutton. I'm a board certified OBGYN, part-time faculty member at Morehouse School of Medicine here in Atlanta, Georgia, with the Department of OBGYN. I also retired from CDC in 2019, so I'm also a medical epidemiologist. And my area of study while I was at CDC and since then has been sexual health, HIV prevention, STD prevention, and awareness for disproportionately affected communities, mostly Black and Brown communities. And since retiring from CDC, I've continued to do work that is advocating for women, especially women of color here in Georgia. And I'm very passionate about health equity and mentoring the next generation to make sure we have a more diverse workforce.
Thank you. Next, we have soon to be Mrs. Chofor.
Hello, everyone. I am Tracy Chofor. I am a pre-med student and hopefully a future OBGYN. I am currently an EMR trainer and currently applying to medical school. Over the years, I developed a strong interest for advocacy, especially as it relates to health disparities, which is why I'm so honored to be a part of this conversation. And I'm grateful to Dr. Ighodaro for having this platform.
Thank you. Then next we have Mr. Nathan.
There we go. Hello, everyone. My name is Alfonso Nathan. I'm a licensed mental health therapist and owner of a psychiatric practice, Brightside Medical Associates. I do a lot of advocacy work for mental health in the Black and Brown community. I'm part of a few organizations. One of them is Black Men Heal, that provides free therapy to Black men to help reduce the stigma. I'm here to provide a testimony as a husband who witnessed the disparities of labor, to provide my story, my family story, as well as just providing just advocacy for families who go through this. So thank you for having me on.
Thank you. So thank you for those introductions. And with that, we will get started. I will ask all the participants to unmute themselves. And part one is going to be setting the stage. And in part one, we're going to be talking about some of the testimonies and some of the statistics behind Black women and the racial inequalities in labor and delivery. So I will ask all participants to unmute themselves and stay unmuted, and we will get the conversation going. And Mr. Nathan, I would like for you to start and talk about the experiences that you and your wife and your beautiful child had in the beginning.
Absolutely. I guess I'll set the stage, right? Yes, like I said, I'm coming here as a husband who experienced my wife's just traumatic labor. Even prior to the labor, the prenatal care was done by a white male. We got a new doctor in the second trimester because we moved. We moved to another location, and just from the initial meeting, it just felt very dismissive, because he looked at us and said, all right, your baby looks good, your baby looks healthy. They didn't even give us like the estimated weight of the baby. And then when we got into the labor process, it obviously didn't go as planned. But even from admittance to just being there, the staff was not, they weren't engaged. It was just more like, okay, let's go through the motions. I felt a lot of going through the motions, a lot of muscle memory prior to anything, until, when it was the labor and we seen a giant head pop out. And that's when it was like, oh snap, this baby's too big. So what happened was my daughter was born 12 pounds. And because of the weight, she came out unresponsive. And she was not responsive for almost about a minute or so. And then, had everybody come in to provide life-saving procedures. And they carted her off, and we left us alone for about 45 minutes without even really talking to us. Came back, and the doctor said, okay, there's chances that your daughter's going to have brain damage, and there's an Erb's palsy, which is part of paralysis of her left arm. And wasn't much comfort. And we were in an area, I do very well for myself. My wife does very well for herself as well. And we're in an area that, where all the individuals did not look like us. It was, and we the reviews of the hospital, I'm not going to name the name of the hospital, but the reviews of the hospital, it was great reviews. It felt like they said it was like a hotel, big rooms, but the care for people that looked like us was definitely not there. So we're now in Pennsylvania. We go to CHOP, and that's when we really knew that we had to really advocate even more. My mother-in-law is a nurse practitioner, and we questioned any and everything to make, because again, even going into that building, it was just dismissed. I have few degrees as well, but I had to let them know about that to even have them give the attention and the respect that we deserve. So it turns out that my daughter didn't have any brain damage, which is, thank God for that, after the MRIs. But even with the Erb's palsy, we've done. I'm big with therapy, so we've done therapy, and she has a strong arm now. But that was a good news. But then every single time we go to a doctor's visit, we have to continue advocating for ourselves. There was a time when my daughter had to get hospitalized, because there was a cancer screening. She had cancer, and then there were a resident doctor tried to give her another diagnosis. And it wasn't until there was a Black neurologist, female, that kind of checked that doctor and said, hey, let's not try to give this baby another diagnosis. She has a live diagnosis. Let's talk with the parents. Let's look at and that was the first time out of being in a hospital setting for quite some time, 8 months, to about a year, that we felt that we were really being listened to, and we didn't have to like push and advocate and just continue showing, our intelligence, continue showing our connections. That one, Black neurologist, I wish I knew her name, that made us feel comfortable. Okay, not every, physician that we're going to deal with, we have to, you know, come up and show ourselves and advocate. And she showed so much, just again, it was just quality of work. She wasn't there for 30 minutes. She was there for 5 to 7 minutes, but just that amount of time of her just being present, that just showed so much comfort and in our belief in the healthcare system. But we still fight every single time, to this day, with any doctor, because we, as a father, I had to realize, I'm not going to, put the full trust into what a lot of these individuals have to say. So any new doctor, we go through the whole list of what we've been through. We go through who we are, and that's still till to this day. And because we felt like there's just so much times where they just go on what we call that muscle memory of just like, okay, this is just another family, another just Black family, and they don't give us the full time of day until we have to show face. So I just wanted to give that testimony of just what we've been through, and just the importance of just advocating for yourself. If I can go back in time, I wish I would have advocated more. But at the end of the day, awareness is, you can't live on hindsight. Hindsight's 2020. But so all you can do is educate moving forward, just about the importance of advocating from the beginning. So thank you for giving me this time. Appreciate it.
Thank you so much for being open and honest and sharing your testimony and your wife's testimony and your daughter's testimony, because the goal of this is to raise awareness so that eventually one day we don't have those stories or we don't have those events again. So thank you so much. And for the rest of the panelists, I'd like for you guys to talk about the statistics. There's been many statistics quoted, and from your experience, from your expertise, what are the statistics?
When I think about having my own kids many years ago, I remember thinking I'm this well-educated maternal-fetal medicine specialist, yet the risk of something, morbidity and mortality for myself, was 2 to 3 times higher than that for an uneducated white woman. That's unacceptable. Unacceptable. And I like to think that I was always a great doctor, but I think just going through the whole pregnancy myself, I got a different perspective. And I myself have to often advocate for myself. And I think the thing that we as physicians have to do is understand that when there are more doctors that look like us, then just that level of comfort that patients get when they see that. And so I've worked really hard to make sure that we're helping other aspiring doctors get to this level.
Dr. Nelson, I want to, speak to a point that you made. You mentioned being 2 to 3 times more likely to die from childbirth than an uneducated white woman. And unfortunately, those numbers are rising because that is the number, as a Black woman, as an educated Black woman, that number is now 5.2 times more likely to die than an uneducated white woman. As we can see we recently lost Dr. Shanice Wallace, who was a pediatric chief resident last year after giving birth. We know influential people who, like Beyonce and Serena Williams, who have all the money in the world, have all the influence in the world, and still had to go through some of these issues, with giving birth and not being believed and your pain not being believed. I believe Serena Williams was experiencing symptoms of a pulmonary embolism, and she knew because she's had them before. And after mentioning this to her nurse was like, well, you're on pain medication, so maybe you're just confused. No, she's in pain and she's going through something, and you should listen to her. So the fact that, you can be educated, you can have all the money in the world, you can have all the influence in the world, but as long as you're a Black woman, your voice doesn't really matter, your pain is not taken into consideration, it's very disheartening.
I think that point is really important for various reasons. I mean, I think the first thing is, I think we oftentimes have to be careful because we don't want to say that because someone has education or someone doesn't, they don't deserve to die, or they deserve to survive, or they don't. And that's absolutely not what we're saying. I think what it does, though, is it speaks to the idea that you have someone who is in health fields, right, who has the education, has connections, so that access piece, which they should have, which you would think would level the playing field, it doesn't. And it basically boils down to the main factor, which is racism, right? I think I'm happy that in the last few years, we've started to become comfortable with the fact that this is the reason. It's not race. It's not because maybe you have more hypertension or more obesity, or you don't, I mean, these things do influence, but the bottom line is racism. And I think that we need to really keep on talking about that.
Yes.
I think the fact that we now have these studies that are showing, first of all, what these risks are and how much higher it is for Black women, and the fact that we're now putting a name to it. I think that women have always been trying to have their voices heard, and they were always poo-pooed. Like, I can talk to you about my mother, who had the same incidents. My brother is 40 years old. And she basically had a physician come in, tell her, okay, he stopped breathing for a bit, but he's fine, and try to leave. She had enough sense even then to say, that doctor is not to be on my son's case. I need another doctor. That was 40 years ago. But I think it took all this time for us to be able to say, no, that's racism. And we as Black physicians have to speak on it. And then we have to educate our patients to speak on it, because I think, like Mr. Nathan said, you have to go to different doctors. Like, if you don't feel like your voice is being heard, you need to get another physician, and you need to start making reports to the department, to the hospital. So there's a paper chain so that they know, okay, this doc has had the same complaint for the last 5 years. We need to look at it.
Absolutely. I'm going to piggyback on a lot of what's been said already, because even here, so I'm in Georgia, I've been in Georgia for over 20 years, and I've delivered all 3 of my sons here. And, with my first pregnancy, I certainly took for granted that, here I am, I'm an OBGYN, I am going to be okay. Other professionals are going to make sure I'm okay. That was absolutely not the case. I had to be very intentional about selecting a provider who turned out to be fantastic, another Black female. And she was a provider. Even when my insurance changed, by the time I had my 3rd son, I got on the phone with that insurance company and I demanded that I'd be allowed to go see her for continuity of care and all that. And so it's absolutely the case that we can't take any of this for granted. And, I started by saying I'm in Georgia. When you talk about statistics, Georgia is, I think we flip-flopped this year. We were number 50 out of the 50 states maybe a couple of years ago. And I think now we're behind Louisiana. Not a good place to be at all. And then even as a country, we do worse when you look at maternal mortality rates compared to other industrialized countries in the world. So we certainly have a lot of work to do. One of the other things that is important when you talk about the statistics and the data, Georgia, as well as many southern states, part of this does have to do with access. Georgia is one of the states that did not expand Medicaid. We, as of about 2018, 2019, we had, I think, about 1.3 million people who were uninsured. Most of those were women, most women of color. And I'm sure that's bumped up during the COVID crisis. And so I think we're in this space where, just like Tracy mentioned, we're probably going to start seeing some of the numbers increase because of all these things that are going on. It's like this perfect storm of public health and just stuff happening, and in addition to racism. So everything is being compounded.
Thank you. Does anyone else have anything else to add regarding the statistics, the studies, or any other testimonies or patient experiences that you've seen or that you've witnessed?
I like to tell a story. About a year ago, my cousin, who is also a doctor, went to the doctor with complaints. This is a doctor had known her for several years, and said, I'm not feeling well. I'm having these symptoms, and she described what was going on. She was, poo-pooed, as often things are, and then she went home. So then the following day, the symptoms got worse. She was having productive cough. She was just extreme fatigue. This is a normal weight, healthy, 40-some-odd-year-old African-American woman. Again, excellent health care, excellent access. That was not the issue. And then on the third time, she went to a different provider and again sent home. And so that night, she calls me around 11 o'clock at night, and she's telling me what's going on. After speaking to her on the phone for 5 minutes, I immediately knew what was going on. I'm like, I'm thinking you have a PE. It was textbook. It was textbook. So I said to her, I mean, you need to go to the doctor now, to the emergency room. This is what you need to tell them. And you call me if they do not admit you. At that point, she was finally got the workup she needed, bilateral PEs. That's, if I can make the diagnosis over the phone, thousands of miles away, yet 3 providers looked at her and looked past her. Not okay.
There's no reason to not diagnose PE. That should be at the top of your list, no matter what. Even if you rule it out immediately and you're using up, resources, that should always be at the top of your list, period.
Absolutely.
Absolutely.
I also hate how hard she had to advocate for her own care.
Yeah.
I definitely think of a time, I used to practice in Texas and I worked at a federally qualified health center. And at the time I was, fresh out of residency. So all my patients had my cell phone number. So, so I had a patient who was recently postpartum and she had a history of preeclampsia without severe features. Went home, did okay, but was checking her blood pressure at home and it was elevated. So she goes to the ER and in the ER, her blood pressure is 180/90. They repeat it, it's 175/90, and they tell her, okay, it's up a little bit, but just go home and rest, you'll be okay. So she's sitting in the ER, she calls my cell phone, and she says, my blood pressure is this, they're telling me to go home, you told me not to do that, told me to call me if there's anything. So I talked to the ER doctor, and she stays, and she gets magnesium, and I think we all have stories like this, right? Like, why do people have to try so hard to get the care that they need? And I think it's just unconscionable.
And I think it also is because of what we see. So I work as an OB hospitalist strictly with the MFM patients. So I work with the high-risk patients all the time. So I'm always thinking of the worst case scenario because most of our patients are extremely sick. And most of the babies I deliver are between 26 and 32 weeks. But that also makes me more aware of subtle cues that I have to look at even when they're 3 days postpartum, when they're in the hospital still and they delivered that baby, you still have to look at very subtle cues before you send them home because we get a lot of bounce backs of women with a PE or they're having seizures at home. Mm-hmm. And when you look back at the chart, you're like, probably could have kept her 1 more day just to be sure, and again, that comes in for us as providers saying, we have to be extra alert and take more care and really take our time. And a lot of times with my ladies, I'll say, you know what, this is probably nothing, but we're going to look into this anyway. And that's what we have to do because a lot of times when we come to the ER, we're way sicker than most.
Mm-hmm. Absolutely.
And I work a lot with residents and medical students. And one of the things I impress upon them is you got to rule out the things that are going to kill your patients and be able to recognize those patients that are sick. Right. And not ignore things. If it doesn't make sense, make it make sense.
Exactly.
That's so true. The challenge is though, how do we get the providers who are not as sensitive to those things as we are to begin to put that on their radar more? I mean, it makes perfect sense, Dr. Nelson. I work with residents and med students as well. And I just can't even fathom how you can have someone who's pregnant or postpartum in a window that we know is already high risk. We know it's the time when it's easier for women to form blood clots and all of those things. We know that it's a time when she can more easily have preeclampsia with or without severe features. And so that always should be on our radar. And I think we have to ensure that providers, regardless of what they look like, are always considering those things, like you said, Dr. Nelson, that can kill. We absolutely have to rule those things out. I'm excited to see some of the work going on in California where, they're developing these kind of standardized protocols to make sure that people use less of these subjective biases in deciding how they're going to treat someone. The more we can standardize these things, I think the more we can hopefully eliminate some of these biases that are unacceptable, and how people are treated, and then when people have bad outcomes.
Thank you. Thank you for your stories, your expertise in sharing those statistics. So now we will get into the Q&A portion for part 1. And this question came during their pre-registration. And the person says, hello, I'm a mommy to be, first child, and I've heard all the statistics around Black women dying giving birth, and I'm honestly terrified. Finding an OB-GYN is so difficult for me. I'm not sure exactly what I'm supposed to be looking for when searching. I lost my mother and my grandmother, so I can't go to them for guidance. How many other females are in this situation? So how would you guys respond to her if she came to your hospital?
Well, I guess the first part of that question is, how does she find that OB? You got to find the doctor that listens to you. There is no other time in our lives that we would pay somebody to give us substandard care. Absolutely not. So if your doctor's not listening to you, fire them. Move on.
Yes. Thank you. I want to introduce Dr. Cindy Duke. Please introduce yourself, and thank you so much. She's one of our also esteemed panelists who has expertise in this field. So Dr. Duke.
Hi, everybody. Good morning. Happy Saturday. I apologize for the late arrival. Thank you so much for having me. So I'm a board certified obstetrician, gynecologist, reproductive endocrinologist, and infertility specialist. I'm based in Las Vegas, Nevada. I'm also a PhD trained virologist, and I'm very keenly interested in what's going on with maternal health, racial and ethnic disparities within the United States, but across the globe. And it's just always fun to join conversations where we're aimed at finding solutions.
Thank you. Thank you so much. So with that, we'll conclude part 1 and we will move on to part 2. So now that we've talked about the testimonies and we've presented the data and statistics, the question is, why is this happening? What are some of the etiologies and what are some of the research that has shown that has kind of shed light on some of the causes of these inequalities and injustices? And that's for all the panelists.
I think you got a couple of components that are coming into play. You definitely, I think the most important factor is racism, but socioeconomics also plays a large factor. So I'm based in Urbana, Illinois as a hospitalist. So this one is, I've been throughout Chicago, but this one is definitely a smaller area than I usually practice. And I think what I've seen is people with a lower socioeconomic status, they tend to have poor care just because of access, just because there's a lot of other elements that's going on in their lives that are impacting their health. Simple things like getting to the doctor's office on a regular basis in terms of transportation makes a difference. So we're looking at racism that is not just the provider or the physician, but the nursing, the person at the front desk. All of these people potentially can create barriers to a patient. And then also social economics. If they don't have insurance and they're dependent on, public aid or what have you, there are a lot of times where we would prescribe certain things that they need to have done, certain imaging, and it's not, allowed by the insurance company. So there are a lot of factors that play a part in this. And so unfortunately for poor African-American women, they get in the crosshairs of both of those elements there.
Yeah, I agree with that, Dr. Collier. one of the things that I found interesting when I was at CDC is that, you know, we look at all these data sets and we do these analyses. One of the huge shifts that happened was that, you know, back in the late 90s, early 2000s, everything was about individual level behavior and individual level blame. What has happened over the years, which I think some of the interventions haven't yet caught up with, was this notion that you can't look at the individual level behavior without accounting for some of the social and structural determinants of health. So they include those things that you mentioned, Dr. Collier, like, you know, access to healthcare. What's the housing situation like? Is there support for things like being able to have an appointment at a certain time if your job is also, quote unquote, an essential worker job? And so we are not yet caught up with how we can have interventions that account for those things. There's certainly going to need to be some federal level interventions happening, because all of those things are tied to these historical racial injustices, whether you talk about historical redlining, you know, historical effects of slavery, disproportionate law enforcement that affect Black and Brown differently. I mean, none of those things have adequately been dealt with. And so by the time you get to the level of a pregnant mom who's dealing with all those things disproportionately affect Black and Brown women. And so you have to go way back into the history of what's going on for people of color in this country when you're going to talk about the causes, and subsequently when you talk about how we can fix some of those causes.
I agree. And I think, you know, we also have to look inward as the people who provide the care. I think it's really easy for us to say, what are the patients doing? What is the community doing? What's the federal government doing? But the truth is, when we say racism, we're talking about the structural racism that's hard baked into obstetrics care in the United States and GYN care. And that means we actually have to confront that. We have to address it. We have to teach it. You'd be surprised at how many OBGYNs are still unaware of the basis for all of our research that's done in this country, even the tools that we use, and how it's based on experimentation on Black women, enslaved women, non-free women, how it was that it was determined that we don't feel pain. And so that was passed on in textbooks, right? Which means if you have a Black pregnant woman, a Black postpartum woman showing up complaining of pain, she's less likely to be believed. And it's not because the people themselves are racist, because, right, that's the pushback. I'm not racist. And we'll get the examples of the Black friend they have or the Black doctor they hired, etc. But the issue is that you were taught from a textbook that told you Black women don't feel pain the same way. So we have to address and identify these underlying issues that have informed how we practice, that informed how we standard of care. And so until we address that, the issues will persist, because that's the reason why a Black brown woman post C-section is still less likely to be given medication for her pain, while someone else who maybe even has a history of opioid abuse will still get narcotics for their pain. But the Black woman, brown woman, because she's seen as not in pain or histrionic. You know, I use this example a lot. I remember studying for my step 1 of my medical licensing exam. And in that review textbook, it literally said that the people more likely to have histrionic personality disorder are Hispanic women. That was in a textbook that I was reading in the year 2003, which means, right, if I read that without even knowing, I now have this implicit bias, because every time a Hispanic woman starts telling me about her situation, my brain that is now educated is telling me histrionics. This is someone who has a tendency to histrionics. And so we actually have to look inward and say, let's reprogram, let's deprogram, let's actually identify the things that were wrong in the system that made it racist. And, you know, it's not, oh, you walked in, you saw a Black woman and now you intentionally were racist toward her. It's that you were taught things that were based in racism. And so while you thought it was the right thing because you were told this is the knowledge, it was actually biased and flawed from day one. And we have to address that. And I think we need some federal regulations, because we're not that great at policing ourselves, because we always want to see ourselves as the best version of ourselves. So waiting for the American College of OBGYN, the American Board of OBGYN to put out a practice bulletin isn't enough. We actually need some people at the top to say, hey, tell me what you're doing about this. Tell me how you have addressed historical racism in the founding of your field, and how are you now making sure every single person who identifies as a practitioner in your field has been aware of this history, has taken training, and therefore knows how to look for these implicit biases.
Yes, thank you. Thank you for those powerful statements, Dr. Duke. You brought up so many good points, and I wanted to touch base on one about this, that our education is based in this inherent racist flaw that Black people don't feel pain. And a phenomenal book that I encourage every single person to read is Medical Apartheid. And in that book, the first chapter, she talks about the father of gynecology, Dr. James Sims, I believe, and how there's statues of him plastered all across the US. There's hospitals, there's colleges of medicine named after him. And this doctor took Black slaves, unanesthetized, and he crafted and perfected some of the tools that OB-GYNs use today.
Yes.
And that is the basis of medicine.
And the problem is that Black and brown doctors, we know that, right? Yes. But other physicians are unaware of that history. They don't see within themselves how those implicit biases are even there. And then if no one ever questions them, if they're not on a staff where there's another Black or brown physician that might question their actions or how they're taking care of a patient, it goes unchecked. And there are tons of hospitals out here that have very few Black and brown doctors. And if they have them, they're focused on one, in one area. But you have to have Black and brown docs in every department. And a Black and brown doctor that's aware of the racism that's there and then has it within themselves to speak on it. So that's why this goes unchecked, because we don't have that many Black and brown physicians, and then those that are there are usually not in all the hospitals that we need to make an impact by at least speaking on it. That's just the beginning. We have to speak on these issues, because a lot of people, they throw their hands up because, I didn't know.
Listen, it's not just the doctors and the nurses, the administrators don't know, the CEOs are unaware. Right? And so they actually think, we're going to solve the issue of maternal mortality at our hospital if we hire a Black doctor, if we hired a couple Black nurses. But it's not that alone, right? You need that. Representation matters. You need people who understand communities, who can talk to patients and reach patients where they are, as opposed to talking down to them. But we actually need the hospital systems to learn exactly how it's hard-baked into their system. We need them to understand that. We need them to understand that it's not enough to say, the patient doesn't eat a healthy diet. It's literally saying, if I'm a multi-million-dollar institution in this city, how have I worked to make sure that the food deserts are solved? How have I worked to make sure that patients have access to nutritious food, to fresh food? How am I marketing, right? So instead of spending $100,000 on billboards this year, maybe the hospital should take $50,000 and actually invest in meeting the community markets and providing that food and really providing that mother's and baby health service that you need. And so I really think that's the conversation that needs to happen. And we need every stakeholder involved, because it's not just the burden of Black doctors, Black nurses. It's not, we're going to do it, and we're doing it without people asking us. But at the same time, it's not just our burden.
And we have to understand, acknowledge, and accept the importance of the cultural impact of the decisions that we make as African Americans. You can say, we're not racist and we're not, but if you think about it, the 1970s were not that long ago, and that's when you get Tuskegee. And if you have a population of people who lived through that, my parents lived through that, understanding what leads them to make decisions in terms of vaccines. Why don't they want to take the vaccines? Understanding the importance of the culture. You know, I think we spend a lot of time on, you know, we have certain populations who don't want to see men, and we respect that. We have certain populations who have these restrictions in terms of the decisions and the people who care for them. Why aren't we respecting the culture of African American people?
Yes.
That's a good point.
We have to meet them where they are instead of saying you come and you follow our culture. This is how we believe. We definitely have to meet them where they are.
And I wanted to give Tracy her platform because she created a phenomenal survey, and I would like for you to educate us about some of your findings.
Thank you. I was going to mention that it's important to note that a lot of the things that we're talking about, how certain doctors don't believe that Black people feel pain as strongly as white people do because of the things that were done in the past. It's important to know that, you know, it still happens to this day. As recently as 2016, there was a survey or an actual study that was done to laymen, quote unquote, and resident physicians and medical students. And some of the surveys they asked them were like, do you think Black people feel pain less than white people? And 50% of residents and medical students said yes. 50%. These are people who have gone through, you know, years of biology, years of medical school. They're actual doctors, and they, you know, they still believe that Black people and white people have biological differences, and that, you know, race is not social construct. But back to what Dr. Ighodaro said. In my master's program, I got the opportunity to do a pilot study. So we got to do a research project, and I chose to do mine on the factors that are associated with higher maternal mortality rates in Black women. So essentially, we created a survey that we were going to give to healthcare providers for pregnant women at a certain health institution. And because of the sensitive nature of this topic, we decided that, you know, we're going to kind of ease into it and give some filler questions. And, you know, ironically, our filler questions give us a lot more information than our more direct questions did. So like one of our first questions was, it was more of a statement, and they got to either strongly agree, be neutral, disagree, or strongly disagree. And so the first one was, the rate of maternal mortality is increasing in the United States. Most people agreed, but there were some neutrals. And then the second one was, Black women have higher rates of maternal mortality in the United States. And we had even more neutral answers. And it's just kind of like, you cannot be neutral about data and about facts. You know, these are things that are easily Googleable, that are well known. And as a provider to pregnant women, you're neutral about this. Either you agree or you disagree. And if you disagree, then we have a bigger problem. But, you know, it's important to understand that it was a pilot study, so our sample size was very small. But no matter how small it was, even if just one provider was neutral about the fact that Black women are dying at a higher rate, that tells you that, you know, we have a big problem, because that one provider, I'm sure they see Black patients, right? And let's say, like the question we had earlier, I'm a new mother. I've been doing a lot of research. I see that Black women die at a higher rate than white women. What can I do to protect myself? What are you doing to protect me as my provider? Well, that neutral provider is probably going to give her a neutral answer, and it's going to sound like being dismissed, which she's probably used to, right? From what she knows of the healthcare system. You know, Black women go in and complain about fibroids, endometriosis, and all these other things, migraines, and our pain is not believed. And so we just kind of have that mentality that, well, every time I talk about my pain or my concerns, you don't really care, so why should I bring it up, right? So you have women going through things in pregnancy, and they don't really, you know, think to talk to their doctors about it because they feel like they're not going to be heard. So anyway, the main finding from our research showed that Black women are more likely to present to prenatal care later than white women. So this is something we actually read about in our literature review. And then based on the questions that we asked, we saw that, so initially we asked, typically, when do your patients present for prenatal care? And I want to say 70% of respondents selected their first trimester. And then we said, typically, when do your Black patients present for prenatal care? And 70% of them said second trimester. And so we started to look at the factors, what are the reasons why Black women are coming in later? And like we said in here, there's a lot of racism, there's a lot of historical background, with knowing that, oh, my grandmother and my mother and my aunts and my sisters have had bad experiences at the doctors. So I'm not really going to go in there unless I really have to, like, unless it's a really dire need. Or, they just don't have access to healthcare. They just don't have transportation. They don't have somebody to watch their other kids while they go to their prenatal visits. They don't have adequate insurance. So there are a lot of things that, we saw that played a big role in this. And when looking at interventions, Dr. Sutton mentioned earlier about what California is doing with their collaborative care quality project. And it's important to note that although it is working because they kind of, look at the clinical aspects of why maternal mortality is increasing, that collaborative was able to reduce their maternal mortality rate, but it did not close the gap between white and Black women. However, North Carolina did have, an initiative that, although not directly linked to the gap closing between Black and white women, most providers state that, it played a huge role in reducing that rate. So what they did was that they have a program called the Pregnancy, give me a moment to just confirm the name of it, the Pregnancy Medical Home, where they have care managers go to low-income women who are pregnant. So first, the state of North Carolina started to incentivize providers to document when your Medicaid patients are pregnant. So once you document that and you look at high risk factors, or is this patient likely to have diabetes? Are they likely to have preeclampsia? Like, if you document those things, they get incentives for it. And then these patients also get care managers who are able to make sure that they can get their medications, their insulin, they can get food, they can follow the diets that their providers are recommending, that they can actually make it to their prenatal visits. And after doing that, so this program was started in 2011, and in 2013, North Carolina was able to close that gap. So it's important to see that the clinical aspect matters, but a lot of the things that we need to focus on are social determinants of health. Mm-hmm. What are the barriers outside of the clinical setting that are causing these disparities? So that's just a little bit of the research that I did.
Tracy, just to jump off of some of the things you said. So when you were mentioning your results as far as what people knew about the risks for Black women and maternal mortality, it made me think of a study that came out, I believe it was 2018, where they surveyed maternal-fetal medicine doctors, about 450 of them they surveyed across the country. And they asked them that statistic that we all rattle off really easily, 3 to 4 times more likely to die in pregnancy if you're Black, right? 48% of the respondents actually got that correct. So if you think about that, these are the specialists, right? So I like to sprinkle that in whenever I give a talk about this, because I feel like education is really important, right? Just as you said, if you don't know, if you have that mom come to you concerned about dying and you don't think that she's going to die or that she has an increased likelihood of dying, how are you going to counsel that mom, right? The second thing I want to comment on is actually there's been some more recent studies out of that California Maternal Safety Quality Initiative, where just doing the bundles, specifically, they have hypertension and they have postpartum hemorrhage bundles, they found improvements in outcomes, and also it is starting to close that gap. So really focusing on the quality piece will, really address that equity piece as well. And it's just that same thing. I mean, you just standardize it. So it doesn't matter what color you are, what you look like. If you have a blood pressure of 140 over 90 or 160 over 110, we're going to get you your meds within 10 minutes. So I think that piece of it's really important. But I definitely have to echo what you said about the patient-centered medical home. That's excellent. I mean, there's just so many other pieces that come into play when we think about morbidity in maternal care.
Thank you. Thank you so much for these references. Someone in the audience was asking if we can share some of the references that we all have been quoting from the different studies. So know that after this conversation, we will be sending out references so that people can educate and know where the statistics are coming from. And does anyone else have anything else to add about the etiologies before we go into Q&A or statistics?
Well, there's genetics to play here too that we need to talk about, which means we need to know our family histories. And amongst communities of color, Black communities the world over, we don't really, while we're great at storytelling, we don't usually tell the family's story of health and medicine. So it's still very common to meet someone, you're talking to them and they'll say, oh, my mom or my grandmother died in childbirth or died when they were young. And it takes a lot of steps to help them figure out what happened and what might be a genetic risk factor here. So, we're working on the social determinants of health. We need to work on the healthcare side, on education, and just getting people to stop thinking that this is a patient problem. This is a systemic problem. But we also do need patients to start getting more aware about family history, encouraging those conversations. One of the things I love seeing with Black communities is we love doing family reunions. We love gathering. And I think we've got to start building into the gatherings a moment for us to literally share the family's history and not feel guilty about talking about cancer. I think in a lot of families, cancer, yes, it's painful, but it's also seen as a personal failing, which is not the case. And so we need to talk about that. We need to talk about heart disease. We need to talk about diabetes. The sugar is really a genetic condition for the most part. And so we need to hear about that, especially if your own mother had diabetes when you, the woman, were a baby in the uterus. We now know how much that impacts your own health, your own risk for diabetes later on, and your risk for complications as it relates to blood pressure, et cetera. So it's really helpful and instructive to hear that and to start getting buy-in on certain changes when it comes to diet, exercise, etc. But we do need to talk with our families. I know we all love our families, but when it comes to medical history, we really don't talk about it, and we need to start doing more of that.
Thank you. Thank you so much. And so we're going to move on to part 3 because there's a lot of questions that are coming up about part 3. So now that we've set the stage, we've talked about testimonies and personal stories, we've talked about the statistics, then we've moved on and talked about some of the causes and etiologies. A lot of audience members now want to know, what can I do? So that moves us into part 3. Where do we go from here? And I'll open this up to the entire panelists and talk about, so where do we go? And we can start from the patient, and then we can work our way up from patient, hospital, institution, state to policy. So let's start with the patient and their families. What is your advice to them, to Black women?
One thing that I often see with my own family is, often older African-American women and men are very respectful. They respect the hierarchy. They respect their doctors. They don't want to question their doctors. And I have to tell my family members, stop that. Mm-hmm. Stop it. And advocate for yourself. Ask those questions. And if you don't get the answer that you need, ask it again.
I think also we have to have our patients do word of mouth about the physicians that they're seeing. You can get a lot of information once we start talking amongst ourselves about this doctor. This doctor did this doctor did that. That's the way you can find the better doctors. And then once we start sharing our experiences with certain doctors, then you can say, okay, this is somebody I do want to get care from, or this is someone to stay away from. And that's just as important too. So I think it's important for us to utilize, how we do every day, word of mouth, talk amongst ourselves, ask people that are in the medical profession, maybe a nurse practitioner or a nurse or a physician, a friend, and ask them, okay, who's someone that you would suggest that I go to, or I think this is what's happening. Get a second opinion from that person. And then, like you were saying, get second opinions. Don't just take what one doctor is saying. If you're not comfortable with that, there's usually a list of people on that hospital site that you can go to. And sometimes, you know, we will focus on one race, a Black physician, but get an opinion from someone who has a good reputation in general.
Like Dr. Nelson was saying, since I did this research, I typically tell my friends, my family, my tribe, anybody I know, any Black women that will listen, advocate for yourself, advocate for yourself. You know, make sure if they don't listen to you, make sure that you have some type of documentation. However, when we were having this conversation on Clubhouse last week, I believe it was Dr. Wright who mentioned that she had a personal experience where she was the patient, she had to be her own advocate, she even had to be her own physician because the physician was like, well, what do you want me to do? So, you know, in those cases, it's difficult. You're at your most vulnerable state, right? And you're a patient. You shouldn't have to be your own advocate as well. Although it is important, you know, it's sad that, you know, the onus is on the patient right now to advocate on themselves. The onus is on Black physicians and providers to figure out the structural racism and make sure that it's not affecting our people at more disproportionate rates. However, it's important that while you're advocating for yourself, see if you can have somebody else with you that can advocate for you. So you're not doing all the heavy work, you know? So that's one thing to keep in mind.
Yeah, I mean, just even from my own perspective, my own experience, I mean, knowledge is so important. You know, prior to my wife's you know, traumatic situation, I wasn't as knowledgeable just about childbirth or just about any of the the diagnoses that my daughter has. As soon as that she was diagnosed with these things, I started researching, I started asking, and that allowed me to feel comfortable to advocate and ask questions and be able to sit in the room and you know, talk with these doctors. So just for family members, you know, just continue researching. I'm not saying just go WebMD. I'm saying, you know, go and you know, again, you know, go and research, ask other professionals. You know, there's so much of there's a giant wealth of knowledge out there. And you know, since then, I've learned so much about just the infrastructure of the healthcare field, as well as just just all the diagnoses. So again, as a family member, just make sure you just research so you can continue to be knowledgeable.
It sounds like that's a common theme, and so I'm gonna intertwine some of the questions that are coming up. From a patient standpoint, where should they go? What should they read? How should they obtain the information, that the accurate information to help empower themselves? What resources would you guys recommend? And if you could post some of that in the comment, and we'll be sending that out post-production.
I was gonna say, one of the things that you should start with is your provider, right? So that's like that relationship you have at your first visit. You know, you tell them what your goals are for this pregnancy. I ask my patients, what is your learning style? Are you like, do you want like the original source data? Do you want the the easy infographic? Like, how do you like to learn? Do you want me to explain it to you? And I think that's a conversation you have with your provider, right? So if anything, they're like, oh, we think you have preeclampsia. Like, what is preeclampsia? Can you give me the information? Ask your provider first, because I will also let you know if you need to continue with this provider. Because if they're not going to give you information, then you need to find somebody else who will, right? And I tell my patients, like, my job, you pay me, I'm your consultant. I will find your information, I'll dig it, we'll explain it, and you figure out what works for you and your family. But the onus shouldn't be on you to be on Google or at WebMD and all those things, right? So yeah, I think that's the first thing. I did want to make a plug, just kind of going back to what we were talking about before. There is a new app that was just, I think, released on this app store. It's been in development for some years now, called Irth, IRTH. So it's taking the bias out of birth. I'm really excited about this app because it's kind of going to be like a Yelp type style of, especially for birthing people of color, to explain what their experiences were with certain hospitals. So I think it will be a great resource for people to find, providers in hospitals. So I just kind of want to put that out there.
You know, I love that you shared that, Dr. Dixon, because I think one of the things I see, which is a dearth of information online and people trying to take very generalized information and personalizing it to their own detriment. So I do second talking to your provider first. So yes, you have to find a provider you trust, but some of the tools I like to emphasize: one, write your questions and your concerns down. A visit can feel like a whirlwind. Even though you're someone who's usually calm, you feel prepared, you show up and things are moving so fast that you feel like your questions don't get answered. The second is I advocate when you call to schedule your appointment, ask them, how long is this appointment supposed to be? And if it's scheduled for 10 minutes, 15 minutes, you can say, can you schedule me for, double book me then? Can I have a longer appointment? It is possible, but you do need to vocalize that. You might end up needing to pay a little extra on your copay. I'm never sure. I think different insurance plans have different ways of approaching that. But in my opinion, paying extra on a copay on a visit is better than leaving the visit feeling like nothing was addressed because you didn't get there. So ask for longer appointments. There's nothing wrong. If the person at the front desk hems and haws say, listen, it's really important to me that I have time to talk to the doctor or whoever your provider is. I need to be able to talk with them. I don't like feeling rushed because it's important to me. I value their opinion. I need to get enough information. I need more time. Bring a friend when you can, whether it's your parent, your loved one, in terms of your partner, a co-worker even, someone who can sit there and take notes for you, someone who can sit there and read the room. Maybe you're not sure about the dynamic and you'd like someone else to give you a sense of what's happening here, right? Bring a friend with you. And then always, I say, get copies of your records. I think one of the things I'm always amazed by is how afraid Black and brown patients are to ask for records. They're afraid that the clinic's going to think they're trying to go elsewhere. They're afraid the doctor is now going to withdraw care. I would tell you, my white patients ask for their records to my face, right? They come in with their records and they want to go over every detail of their labs. And so there is absolutely nothing wrong with asking for your records, bringing your records with you. The other thing I say is if you've seen a consultant, you should get a copy of that consultant's note, especially if you're pregnant and you saw a high-risk obstetrician. You should have your copy of your high-risk obstetrician's note, especially if you're traveling, so that if you show up somewhere else in labor, in preterm labor, etc., you can whip out that note to say, this is what the high-risk obstetrician who saw me last wanted to be done for me in pregnancy. And I feel like that happens way too often where people don't have that information. And so, it's not the fault of the new place you show up to, but if you show up and they don't know anything about your high-risk pregnancy history, they're starting from scratch, which may delay things happening for you. Whereas if they have a place to start from, they can then say, okay, let's build on this sooner. And so that's my 2 cents. Oh, and as for multiple means of communication, many offices now have text messaging to the office, portals, etc. That's the way to keep communication lines open as well.
Thank you so much for those very key, phenomenal advice. I had a question that come in from the chat.
Oh, no worries. Sorry I couldn't answer. I'm in the middle of a meeting right now, but no problem. Thank you.
Okay. And the question. Thank you so much for this question. And the question is, I'm reading verbatim. I personally had a very traumatic experience near death for both of my child and myself, where I coded twice. Many systemic and bias factors contributed to this. My question is, how do we prepare our daughters in a preventative manner to address some of these issues?
I'd love to start with that because I think some of it probably piggybacks on what has already been said. And first of all, I'm glad you're okay. If you're here asking that question and you survived what sounds like it was a very traumatic experience, probably the most important thing, one of the most important things for you to share with your daughter would be as much detail as possible about what happened to you when you coded. When you code, that's, as you know, that's a serious life or death situation. And if there are some things that may be related to genetics that may have been part of the picture of what was going on medically, having your daughter having that information will help her advocate for herself and also inform her providers so that nothing comes as a surprise. you know? And so I would say that sitting down and when the time is right, having a very detailed, thorough medical history about what happened with you would be something that would absolutely empower her when it's her time in the future to, you know, if she chooses to get pregnant.
I would like to piggyback on that and say, not just your daughters, your sons. I have 2 sons, and I've given them from the day they were born those tools to question things. And just like Mr. Nathan here, sometimes you're the other person in the room. Sometimes you're the person who has to ask those questions and know what your resources are. So daughters and sons.
Thank you. Thank you so much for that. And thank you for the question. So now that we've talked about at the individual level, the patient, next would be providers. What can providers do? Especially our allies. What can they do to help, you know, help eliminate this issue?
We have to be willing to police ourselves and to call our partners and our colleagues when they're wrong. Make them uncomfortable. Ask those questions, and when things happen that are not right, say that it's not right. You got to name it before you can deal with it.
And I think you have to utilize these department meetings that we have to go to so frequently during those times. Then that's when we also, like Dr. Nelson saying, you know, ask specific questions, make sure you get appropriate answers, and then give them the opportunity to say, hey, as a person who is African American, this is how your action could be perceived. If that is not what you want their perception to be, here are some things that you can do in your approach and how you speak. You know, give some small tips, but also make sure we're following up with the department chair and following up with them to see, okay, as a department, what are we doing to focus on these things where we're failing our patients of color? What can we do to improve those? But I think in these department meetings, that's where we start talking amongst ourselves with our fellow practitioners.
And recognizing that allyship is not just performative. It's not enough to say, I'm an ally, right? We actually need you to do the work. And so doing the work means actually learning about your own implicit biases. Saying I'm an ally, therefore I have no biases is not enough. We all have biases. Even as a Black woman, an immigrant woman, I have my own biases that I have to always unlearn. I'm someone who now lives in certain neighborhoods. I have to remind myself what it was like to not be able to pay every bill every month if I wanted to pay them. And so it's important to always remember that allyship is not simply identifying as such, but doing the work and recognizing it's always work, including that personal growth, that personal knowledge, that recognizing how things change. You know, allyship is simply being in your 40s and dealing with a teenager these days. That's, you actually have to learn what their world is like, right? And so when you call yourself an ally, really take it to the next step. And then ask yourself, what does my allyship mean to the patient, mean to my colleagues, mean to my community, mean to the country and the globe? Because way too many people are just saying, I'm an ally. And they're like, yeah, but what does that mean? You know, we need you to do more. And part of that is personal.
I think departments also need to focus on what's happening in their labor and delivery units, right? So what are the outcomes? Are we looking at quality? Are we looking at what are the disparities at our specific hospital, and what is our plan to actually address that? I think a lot of times it's been sexy to be like, we're going to do implicit bias training, and I'm not trying to poo-poo that. I think that's really important, but that has to be longitudinal. It can't be like a half day on a Thursday. Good, we did it, guys. Like, we fixed the problem. No, this is continual. This is like all year, every year, and anti-racism training as well. I know when I was in Illinois, I was working on a project where we did implicit bias training for everyone who was on the labor and delivery unit in 2 of the main hospitals in that city. So like anyone, dietary, like anyone who stepped foot on that floor had to do that training. And our goal was to continue this, not just a one-stop shop. So I think that piece of it is really important. And I think the other part of it, which it's so I get conflicted, right? Because I think I forgot who this quote is attributed to, but I love it. And it's basically, it's not the job of the oppressed to fix oppression, right? So I think a lot of times, you can see our panel today, we're in this space, we're passionate about it because it's affecting ourselves, our families, our patients. But, if you look at Ohio data, for example, 9% of OBGYNs are Black. So it's going to take the other 91% to contribute to this, to really fixing this problem. So it's like twofold in that way.
Indeed.
I'd like to.
Oh, sorry, go ahead.
Go ahead. Okay. I was just going to say, I'd like to plug in a resource that I got as part of SMA's Health Policy and Legislative Affairs Committee. It's called the Social Determinants of Health Academy, which basically has virtual trainings like Dr. Dixon was mentioning about health disparity trainings or enabling services trainings, like basically making sure that your patients are able to make it to appointments, So these trainings are online, they're virtual, and they're just basically to help facilities and practices and healthcare systems to develop and implement interventions related to social determinants of health in their practices to see if that improves their maternal mortality rate. So go ahead and drop that in the chat for you guys.
And lastly, if I would hope now that the Corona pandemic happened, that everybody has incorporated virtual models into their care system. Because for so long, we've known that was a big issue for accessing care, yet it was, well, if they can't make it here, oh, well, they don't care enough. And we know that's not true. So I hope now more and more people are going to be willing to incorporate that into their care model so that your patient doesn't have to see you for every single visit in person necessarily. We've figured out now how to do that. And I hope that's part of the option. So if a patient calls and says, I can't make my in-person visit this week, the front office should be prompting to say, would you be able to at least meet virtually? Can we help you that way? That way you keep that contact. So I'm excited about that too.
It looks like we have a question for Dr. Dixon. What do you think about the impact of underrepresented minorities in high levels of hospital administration positions would be? Should there be a pathway to move physicians of color into these positions? That's a great question.
Yeah, no, it's an excellent point. Absolutely. I think at any juncture, there needs to be people at the table, right? And especially when we think about the higher levels of administration that have the powers to be like, this is what we're going to do as an institution. We need more people in those chairs. So, I think that would be a really excellent way of ensuring that we have that diversity up there. So I think that's a great point.
And so now that we've moved from the patient to our allies, now let's talk about, and this kind of transition as well, to the institution and then policy.
I think a lot of, if anything good has come out of this, is that a lot of people are asking the questions now. And California has done a really excellent job in terms of their quality collaboratives. And a lot of other states are piggybacking those things, understanding that the toolkits help. Making healthcare standardized helps. In Illinois, our latest collaborative in the Illinois Perinatal Quality Collaborative is looking at health equity. And so that's kind of where we are.
I really think, hospitals need to do more in their communities, including bringing people from their communities, the zip codes they're serving, to serve on boards, etc. Like last night, I was rounding up my hospital really late because I had a teenager that I operated on yesterday. And usually I don't, but I happened to be walking past where, they have all those photos of the board of the hospital. And I paused because I was by myself and there was nobody because it was after 10 at night. And I'm like, just look at this. And it was nice. The CEO of the hospital is now a woman. There's definitely diversity, but there wasn't a single Black doctor. There's one Black woman on that wall of at least 16 photos. And she isn't actually a member of the board. She's a liaison to the board. And that immediately told me we have a problem in that form of representation. But also, again, just the the community, right? Like if you're not talking to the people in your community, it's not enough to send your marketing person out to go talk to people. You need to bring the community in as part of your boards, and they can do it. They can do it. Instead of only making your best friends, your local philanthropists, your local celebrity board members, actually bring the people in the community who serve the community, who know the community as part of the board from an admin standpoint as well. And I think when it comes to maternal mortality, absolutely, you should be having women from different demographic groups in the community on your maternal mortality boards. You should be talking to your doulas, etc. You need to hear from everybody, not just the people who are delivering at your hospital, for example. The hospital is really the end user in that, the end point. But what about the people who are serving those at home? We shouldn't just ignore them. Home births are happening. We need to talk about what people need and how do we support them should a situation arise. What's the support system in place?
And I like how you brought that up, Dr. Duke, because that was a question that some of the pre-registrants had about, using midwives and using doulas to circumvent the hospital setting. So would you guys like to comment on that, please?
I love the idea of working more with midwives and doulas. I think the maternal mortality situation is such that, it's kind of an all hands on deck situation. And doulas and midwives, these expanded teams that include the docs, the midwives, the doulas, the nurses, everyone, I think it allows more things to be in place so that that mom is getting what she needs. And, that's absolutely important. We, in Georgia, we haven't seen probably enough of them, but I don't know if the person asked the question this way, but I think the way you said it was, instead of the hospital, I think it can facilitate a coordinated relationship. Now, of course, there are going to be some people who might want to stay out of the hospital to do home deliveries, and that's fine if they are in a safe situation to do that. But absolutely, in terms of hospital care, especially when we get past COVID, the challenge has been for the extra support team members who come in for a pregnant woman. How do you do that during COVID if we're limited and just with one person? I think I haven't seen it done in Georgia, but I know in New York City, they were doing like these innovative iPad things, and doulas were able to communicate in addition to there being one family member in the room with someone. And so, for the remaining time that we're in this thing with COVID, we're going to have to get innovative to make sure that women have these extenders of their OB care that they need so that they don't slip through the cracks. I've noticed some people slipping through the cracks here in Georgia, just in terms of not being able to access care. Things happened as jobs were lost and just a whole bunch of things. And so to the extent that we can have more of those safeties in place, absolutely, we should be working more with midwives and doulas and anyone who's part of the team.
Definitely agree, Dr. Sutton. At Northwestern, we've incorporated midwives on labor and delivery. So ask those questions. Ask the hospital, are there midwives that are available who can be part of the team? Definitely, my population of patients are not generally candidates for home births, but recognizing that all midwives and all doulas are not created equally. So do that work too. Making sure, what is the plan B? What is the affiliation that home birth center may have with a hospital? What are you going to do if something doesn't go just textbook? So do the research on that side as well.
The reason why I bring it up is because this is exactly it, right? And so we have people who are agreeing to do home births, being told if something happens, you're going to have to go to the emergency room. Don't tell them we were trying stuff at home. That is not healthy, and it's not safe even for the baby. And so we have to reach out and make those connections, make sure the community knows that it's not an adversarial relationship here, because right now, everything is being premised on adversarial relationships, and it's us versus them, and I have to choose this or I have to choose that because you can't do both. We have to make sure that we're really empowering people for safety, because some of these stories you hear, unfortunately, they do include something that started before the hospital. The hospital is the final step of the bad part of the story, but we're excluding it. I happen to have been privy to learning about some of these cases, and some of the things that are excluded from the story, actually you're reading and you're like, actually, this is really relevant to what ultimately happened. And so we have to get out there. We can't sweep things under the rug. The conversation must be had. We have to empower the people who are great at what they're doing, make sure they feel safe, feel welcome, but also identify where things aren't necessarily safe and why it's not safe. If we just say it's not safe, people will push back because they'll say that's just big money, big hospital, not wanting to lose money. But we've got to talk about the fact that there are certain things that do make things unsafe, and the community has to feel safe accessing services when that arises.
Thank you, thank you. So now let's move to the community and the system. And policymakers and our government officials and senators, how can they play a role in eliminating racial disparities in labor and delivery?
Oh.
I'm getting deep here.
You know, so I'm in Georgia, and you know, I know that there are groups of people who don't want to discuss politics, but elections absolutely matter. You know, in Georgia, we've had so many hospitals close over the last few years, some of the hospitals in the more rural spaces. And what that does is, you know, that increases the length of time that some women have to drive to get to a hospital. That decreases the chance that if a woman is out in a more rural area, that she'll have the time and the transportation to take that drive and go see someone else. It increases the chance that someone might come in when they're almost due to deliver a little bit sicker than if they had been closer to another facility. So I say elections matter because, you know, when you look at the details of what different candidates either want to do or have not done if they were already there, it absolutely should inform how you cast your vote. And that vote should ideally be, if a priority for you is maternal health and reducing these racial ethnic disparities, your vote should be aligned with those who are advocates for women. Okay, I'm gonna just say it like that.
You know, when I was a resident training in Baltimore, one of the things that struck me, and I became a fan of Congressman Elijah Cummings, was he liked to come visit the hospitals and tour even the birth units. And while, you know, people say again, it's political, it's for show, for me as a young Black trainee, that said something, right? It said to me that he was more likely to bring up maternal health issues when he's in Congress, or more likely to have a conversation about it if advocates showed up as opposed to just the lobbyists for the companies and the big organizations. And so I definitely think if you're a policymaker, you should also get a sense of what's happening. It's not enough to call up on the phone and talk to the person you know and ask them what's your take on this. Really get out there and have a look, see, walk your community, talk to your community, convene panels of your voters, find out from them what their experience has been and what they need you to do. We need a lot of work when it comes to health policy surrounding maternal health, fetal health, when it comes to postpartum care, certainly fertility. Oh my God, let's not even start there, right? And right now in the Black community, the fertility myth is killing us, which is everybody believes Black women are just fertile. So we never have to talk about infertility. And that's a whole separate conversation we're being underserved as well. But really and truly, if you're a policymaker, it's not enough, again, to be performative and say, I care about maternal health. I care that Black women are dying 3 to 4 times more likely. What I want to see now is that you're actually showing people in your campaign, in your mandate, you're discussing it, you're talking about it, you're bringing it up in the debates. I want to see that you're writing bills, writing legislation. You guys have our text numbers now. I want to see you texting me, telling me what you're doing about it, when the bill is coming up, so I can make a call to ask my representative to vote for the bill. I want to see you guys use all the things you use to send me a daily email from your whomever is a party chair asking me for $5, $10, $50. I want to see an email like that too about maternal health. I haven't seen it yet and I'm waiting. I want to see it. I want to see that you want us involved with you on this fight.
I think it's also important with policy and also with funding. Like what we're seeing on the south side of Chicago is we have a lot of hospitals that are on the verge of closing, that are in bankruptcy. And unfortunately, when we talk about the social economics, so you have hospitals in areas where people walk to go see their physician, they walk to the hospital. So when these hospitals close, it's not a matter of, oh, I'll just go to the one up the street. They just don't go, or they have to be, carried in by EMS because they're near death, because people don't have access. So when we're talking about writing policies, we also have to have our representatives realize that we need the funding. There's no reason why these hospitals should not be able to have the funding that they need. And we had a situation where the hospitals were going to bind together and try to make one big conglomerate, and they had to stop because the funding was not there. So it's one thing to say we're going to put a policy together, but if you don't have a hospital in the neighborhoods where people of color are being taken care of, those policies are still not going to be effective because the hospital is not there.
Yeah. I mean, just on the business side, for because me owning the medical a psychiatric practice, increasing the reimbursement rate for like state insurances. You know what I mean? A lot of times, just on the business side, each insurance company pays differently. So the privatized insurances pay a lot more than the state insurances, and that's a lot of times the funding it's not there because the reimbursement rate is so low for these state insurances. So I mean, even talking with our lawmakers and talking with them about understanding the importance of having that reimbursement rate increase, so we can have quality practitioners being in these community clinics and feeling like they're not taking a pay cut just to be inside these certain clinics. So just from my experience on the back end of it, that's why I see where where some things may be missing.
There are creative ways to fund the gap too, right? So maybe Medicare, Medicaid only pays for a certain amount of this, but what are you doing to help that clinic and those facilities function? Are you helping to subsidize their rent, their fees, what are you doing to fund the gap? What are the grants available to help them stay open so that they can serve these communities? When you look at need, a birthing center need isn't only financial, but you do need to subsidize some of it if you want to serve a community that's not in terms of large numbers, and I used to do locums in the Berkshires. I covered a hospital that had 275 births per year, yet it's highly funded because of who lives around there and what they contribute to funding gaps and making sure that there's always a doctor there on call, even though you'd work there for weekends on end. Not a single person will come into labor and delivery, but it's staffed and it's funded. And we've got to take the same approach with our communities, our Black neighborhoods, our Black communities, our rural communities. And we have to ask those questions, and you're right. We have to come up with creative plans too for funding these things and incentivizing them staying open, including covering student loans. But
anyone have anything else to add as we are nearing the end of the conversation? And then we have a lot of questions that did not fit in between part 1, part 2, part 3. So then we'll add a part 4 where we talk about some of the other questions that are coming in from various social media platforms. Okay, so let me pull up some of these questions that people are asking. This is a good question. How does it feel to be an underrepresented physician in a predominantly white hospital system? We're getting deep.
A lot of us, that's just we've been doing that for a long time. Once you get out of high school, depending on where you went to college, that's just a repeat of college, residency, you know, so you get used to it. And I think you just learn how to A, advocate for yourself, and B, be comfortable in your own skin. Because if you're not comfortable being the only person, then you lose your voice. But I think for a lot of us, or specifically for myself, that's where I've seen myself in since college. So it's just you get accustomed to it.
Yeah, you get accustomed. You also learn to recognize the biases, and you know what patients are undergoing because you face it yourself. You know, as a surgeon, I have definitely worked at hospitals where it doesn't matter how many times I give them my preferences, they never seem to know what I need in the OR, right? So suddenly your surgical cases are being logged as longer, but it's not because you're slower, it's not because you're a worse surgeon, but it's because they're taking forever finding you your tools that they're supposed to have and that they have ready for everybody else, right? It's things like that. It's, you know, making sure you're vocal or else we get overlooked, you know. So the question about how do we get more Black doctors, et cetera, in admin roles and at the top level in the C-suite, because really that's what we need to get to, right? We need to get to the C-suite. The C-suite is ultimately where that money is coming from and where a lot of decisions are being made. And yet we're often not the people in the C-suite, we're the people supporting the C-suite, we're the admins and the executive assistants, but we're not making the decision. So, you know, I'm vocal and I point out, I think I encourage everyone, including if you're a patient, if you're a person out there who actually has some means and you're a Black person, it's not enough to say, oh, I go to fundraisers and I'm seen. You've got to take it to the next step. If you're a Black person with means, with money, you've got to start asking your friends and saying, so who's on your board? Who have you brought into the board? When you were hiring for that position, who did you consider? How wide was your search, right? And I think that's a big part of what I do as a Black woman in medicine, a Black woman. Like, you know, I saw that wall last night. I happen to know the CEO. I'm going to message the CEO to say, hey, I don't know, the board is very diverse. There were lots of women. It was nice to see that, but I actually noticed there were certain things still missing. You know, what are you doing? And I feel like I also have that rapport with her, so I'm going to bring that up. But no, we face racism, we face biases, we face racism from colleagues. We are Black doctors, but still more likely to be thought of as Black women as nurses. A Black male doctor is more likely still to be seen as, you know, a janitor, etc., support staff, unless he says I'm Dr. So-and-so. And so we face that, and we all have very creative ways of pointing it out. We'll chuckle and then throw the shade. Well, I'm the doctor, you know, or some of us will just sit there and let somebody make a fool of themselves and then later say, oh yeah, by the way, I'm the doctor. But really, you know, it's a struggle, but in no way does it mean we're not going to fight for our patients. In no way does it mean we're going to give up. You know, I think it's a great question, and there's no one answer to how we do it.
Thank you. Thank you for that insight. Here's another really good question that comes from the audience. Is VBAC really as dangerous as some doctors say? What makes C-section so dangerous? And why is it that it seems African-American females are having more C-section than other races?
So let me take that one. So VBAC, or vaginal birth after cesarean, it depends on what kind of C-section you had the first time around. With a prior low transverse cesarean 1, and we're now seeing 2, the risk of uterine rupture is less than 1%. When we start looking at classical cesarean, that rate of uterine rupture increases 5 to 7%. I think that as a country, we're doing too many C-sections. And in my other capacity, I am the director of our CRETA Center. So I'm the doc who does the big cesarean hysterectomy. And that's why we got to stop. We got to stop. And often my first question for my patients who are coming in for that consult, for that cesarean hysterectomy that I'm going to do for them, is why did you have the first C-section? And it's not necessarily to be, you know, placing blame anywhere else, but you got to start thinking about it. And as obstetricians, we got to start thinking about it when we're doing these C-sections, because, you know, women are having larger families. I have had women this month with their 6th and 7th C-section, and that's it's just unsafe.
I think the other piece to look at is how we counsel women their risks for a vaginal birth after C-section. So there's a calculator that has been developed from the MFMU that you learn to use as a resident, and basically you have to plug in a bunch of different factors, including the patient's age, their race, their why they had that first C-section, if they've had other vaginal deliveries. And specifically that race piece will change the chance of success that's spit out by this calculator significantly. I use myself as an example. I had a C-section with my son, cord prolapse at 9 centimeters as a true OBGYN. So, so with that said, I'll put my data in, and if I were to have another child using all my demographics, I would have about a 55% chance of success. If I change my race to white, it changes to 72% chance.
Wow.
So you can imagine, you know, for someone else, how they could counsel somebody, the difference between 55 and 72. So that's actually something that is actually being considered. They're repealing that part of the calculator because it is having an influence on how many women are now opting to say, well, I'm just going to have a repeat C-section because my chance isn't that great.
We know that once you have that first C-section, 70% of women are going to go on to have a second C-section. So
I think it's important that we challenge the data for a calculator because like we were talking about, a lot of our data, even, you know, those who know me know I'm someone who's very much big right now on interrogating all these artificial intelligence systems coming out, because again, your output is based on the input. And so what is it that informs the calculator? And the truth is we do have to go back and look at the racial factors that were determined when they were calculating the risk related to race from the data they collected. And there definitely were flaws because we know a lot, and almost anything that was based on race that was data collected prior to 1990 had huge biases, and even just the way it was collected far more the way it was analyzed. And so we do need people to go back now and really do that deep dive, aware of the biases and really recalculate. Now we may discover that the risk is even higher when we factor it in, but I do think we do have to go back at a lot of this stuff that we've been using to counsel patients on outcomes now that we fully appreciate and understand how biased the input was many times for the determination.
I'm a little biased because my colleague was one of the people who came up with the calculator, but I think that we got to understand how we're using those tools. It's not the end all be all. It's the starting point.
Correct.
And Dr. Duke, I love that point about challenging the data. And me as a neurologist, that's what I'm trying to do in my own field. We have these statistics, and it spans not just OB-GYN, not just neurology or pain, but all aspects of medicine. African Americans have poor outcomes because of X, Y, Z. And how are those studies created? How are they designed? And what are some of the challenges, considerations, and adverse outcomes for using race, and not so much, we call it race, but not racism. So, I'm glad that you brought that up, and I'm glad that different physicians and different providers are challenging that so that we can start naming it correctly. And then with that, we can treat it appropriately. So thank you for bringing that point.
Like right now in this pandemic, we have been seeing this disparity, which is lots of people who went to the hospital complaining of issues related to COVID and were sent home or were not put on oxygen fast enough, and nobody considered the fact that the way we measure oxygen actually there's disparity built into the technology, which is the infrared can't read past a certain level of melanin very well. And so if somebody's saying, I'm having trouble breathing, it's not enough to say, well, your oxygen levels are fine, you're being histrionic. And we saw what happened with Dr. Susan Moore, despite her saying this. And it's because we're not aware of the disparity baked into our technology and baked into the data that we're so heavily reliant on. Yes. We call it objective, right?
Yes.
See it with strokes, where people, the stroke scales, again, there's implicit bias built into the way those stroke scales were determined and how the chance of success were determined because of the bias in the analytics and collection of the data. And so we actually have to go back. And I'm not saying this to make people out there be distrustful of science. That is not what I'm saying. What I'm saying is is we are aware of the limitations of some of our science, and now we have to go back and fix it. The data isn't what's lying. Like, the numbers are there, but we have to make sure the numbers were collected correctly, they were analyzed correctly, and the appropriate amount of weight was put on the data. You know, right now we're proposing to use remote oxygen monitoring to determine if to send an ambulance to people. But if the oxygen monitoring isn't accurate, we're going to end up saving a lot more people of a certain hue, and a lot of other people who are savable, who could have been saved earlier because we relied on this technology that is actually disparate in how it was designed.
Yes, that is point on. And this, I love this question. I'm getting ready to ask another question that kind of ties back into, this might be more of a long-term solution, and that diversifying the field of OB-GYN, the field of neurology, the field of medicine. And so we have a fantastic question coming from a student that says, do you have any advice for a struggling pre-med student with a low GPA who wants to be an OB-GYN? And trying to answer that question, how can we start to provide resources and mentorship to people that look like us so that they can go through, get through the medical school, residency, and help be at these tables and be at these institutions and make change for our people?
I'll be happy to take that. Naima, I hope I'm saying your name correctly. So I just wanted to let you know I'm kind of in the same boat. I graduated undergrad about 6 years ago. I did some career work. I am currently studying for my MCAT and applying. And I just want you to know that it's important that you don't tie your identity or your self-worth or your success to how well you're doing or how well you're not doing, right? Your successes and your failures don't define you, and whether or not you become an OBGYN for whatever reason does not define you. It's important to keep the reason why you want to be an OBGYN at the forefront of what you're doing. Like I am, the process is not easy, but the things that I'm doing, like advocating, remind me why I'm here, right? It keeps the fire under me to keep going. And there are a lot of resources I'm happy to share with you. If you reach out to me, you can attend a post-bac program that will enable you to enhance your GPA. You can do a master's program like I did that will make you a better applicant. So just be sure to reach out and I'll be happy to help you.
One trend I'm seeing is I interview students for med school for here at Northwestern, is disproportionately the white students are taking that gap year. They're taking the gap year, and during that gap year, they're studying for their MCATs. They're building their resumes. They're doing those things, and we're not always doing those things. So embrace the gap year sometimes. You may need to do that.
I think, gap year for some people it's a struggle because you need the money, etc. But also look at creative ways to do your gap year. Maybe going to another country even where cost of living is lower. Same thing goes for medical school, right? You can attend medical school that's outside of the US, but come here for your clinicals, etc. So there's that too if the GPA/MCAT score is part of the problem. But one of the things I like to encourage, which I didn't even know this existed until I got to medical school at a PWI, and they have a whole test-taking center where people can assess your test-taking style, assess your learning style, so that you actually start getting your tools. Many of us have ADD, ADHD, and haven't been diagnosed, and so we're struggling. And of course, also culturally, as Black communities, that's a diagnosis we shy away from. But the truth is, it's an important diagnosis to make because one, it helps you then learn how you learn and figure out ways that will help you focus, concentrate. I know so many people who are amazingly smart, but you sit in the test and you just can't focus on the words there for the test. So of course your GPA, which is the objective output, suddenly looks like you're not capable. And so I would also invest in figuring out your learning style. Figure it out if you have ADD, ADHD. I know a lot of amazing doctors, lawyers, engineers, scientists who have ADHD. So you can be amazing and have that. You just have to get diagnosed. And there are more and more Black people being diagnosed with ADHD in adulthood because it was missed in our childhood. And so I would look into all of that, but I wouldn't give up on it. I know also many non-Black people who struggle with GPA and are still doctors today, who didn't have high MCAT scores and are still amazing doctors today. So in no way is this a Black thing. Don't let anybody tell you, well, because you're not cut out to be a doctor. Now, maybe you don't want to be a doctor, so ask yourself that. But if you really want to be a doctor and an OBGYN, I wouldn't just give up because of a GPA. It's a number. It's a number. And, you know, you ask us nowadays, what was our GPA? Most of us don't even remember what we even scored on different classes because it's so distant now. So please.
I would definitely like to echo that. My husband, I met him in med school, and it wasn't until med school when he realized that he was having trouble, and he was diagnosed with dyslexia in medical school. And I mean, he's still a doctor. And I think that oftentimes we as African Americans don't like to embrace those things. But then fast forward, when my 9-year-old was having trouble with reading, he has dyslexia too. And you give them those tools and you build forward, and don't let the labels keep you down.
Absolutely.
The other thing is, I feel really passionate about this as someone who, had the experience of people telling me like, well, maybe you don't want to go to med school. Maybe you don't need to do that. And I know this is my passion and I'm happy I'm here. Right. But I also know what it's like to excel in high school and then get to college and maybe not excel, right? To like start to struggle for the first time, maybe in your academic career. And things that I wish I had done as an undergrad: go to office hours, stay on top of your professors. If you're struggling in class, ask them, is there another test I can take? Is there another assignment? Because surprisingly, there are. And a lot of times it's not publicized and you don't know that. Does this test count? Can I get it thrown out? Surprisingly, you can get some things thrown out if you're on top of people. So, that type of thing, making sure you're getting tutoring, asking for help while you're an undergrad. And then I've also been involved with admissions for various med schools in the past. And, a lot of us are moving towards holistic review now, which is great. So that does mean, like everyone has said, like, yeah, maybe you don't have the strongest GPA, but you're volunteering, you have research, you have your physician shadowing. So that will help bolster your application. And just like everyone said, don't give up. Reach out to any one of us. I'm sure we'd be happy to help you through this journey and get you to be another one of the OBs up here.
Thank you. Thank you so much. And I'll be listing everyone's information on the description. So for those of you in the audience who would like to follow up or contact some of the panelists, with their permission, I will be posting that underneath the description. And in order to respect everyone's time, as I know we're all extremely busy professionals and individuals, we're nearing the end of this panel discussion. And so what I would like to do now is for each of the panelists, one by one, to give last remarks. And we'll start in alphabetical order. So first will be Dr. Collier.
Oh, wonderful. I think last remarks, I think the panel was very informative for myself as a participant, and hopefully for those who were getting the information from it. I think that we have to think long terms about how we're going to improve our situation, and just try to see where you can fit in. Each of us can contribute to improving this. You just have to see where you feel comfortable, where you fit in, perhaps mentoring students, perhaps working within administration and being one of the administrators. But I think that we have to look long-term and know that racism has been here for a long time. So it's gonna take us quite some time to change some of the things that have come out of that.
Thank you. Thank you for that. Next, we have Dr. Duke.
Well, thank you so much for having me. This has been an incredible panel and conversation, and I can't wait to go watch the replay. I think, the more conversations like these that we have, the more we're going to move the needle and move it in a positive direction. I encourage everyone out there to feel empowered, take as much as you can from this conversation and share it. Get more people involved, get them hearing, learning different strategies for the conversation and how to talk about it. Definitely, we see the power of a vote. So vote, and vote not just for the national elections. It goes all the way from school board right back. Our health starts even at our schools. It starts at our places of worship. So get out there and advocate when you can. I know it's exhausting. So self-care, 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 but definitely ask as much of others as you ask of yourself. And that includes the allies, right? That's really my take on it. And so it's not enough for people to say, I recognize this is a problem now. I think it's great that people finally are okay saying things like Black Lives Matter. But you know, we never started saying that just so we could say it. We were saying it so that we could now get a call to action going for change. And so it's time to start saying, where's the change coming from? How are you committing to the change? And how are you making sure the change is going to be sustained? Because we're not looking to go back to the old normal. Nobody wants old normal, not even when it comes to the pandemic. We want a new normal with equity and equality and justice.
Thank you. Thank you so much for that comment. Next, we have Dr. Dixon.
Yeah, this has been an excellent panel. Thank you so much for letting me be involved. I've learned so much from all the ladies and from Mr. Nathan on the stage. I would just say speak up, right? So if you are a patient, speak up for yourself, speak up for your family members. If you are a provider, speak up for your patients. And if you are also a provider or wherever space you're in, speak up for the allyship for making sure that this doesn't continue, right? So it's like getting to the point where you realize that your voice is important. I feel like I say this to my patients every day, all day, every day. Your voice is important, and really recognize that and speak up.
Thank you. Next, we have Dr. Nelson.
This has been a wonderful, wonderful conversation, and I thank you for including me. I think the thing I'd like to leave with is that we have to be informed consumers of our healthcare. You got to be willing to ask the questions. You got to educate yourself, and then demand the level of care that you deserve for yourself and your families.
Thank you. Thank you. And then next we have Dr. Sutton.
Well, thank you. This has really been great, Dr. Ighodaro. Thank you for setting this up. This has been excellent. To think that I think I just bumped into you on Clubhouse and ended up here. So it was a wonderful discussion. I'm excited to meet all of you and have an extended family of colleagues. I'm going to direct, I think, my closing comment to the Naimas who are listening or who may not be listening. You know, earlier this month, we celebrated February 8th, the very first National Black Women Physicians Day. Wow. And the number that I thought was just so powerful that we've been hearing about for years is that Black women make up only 2% of physicians who are out there. And so what I want to say to Naima and others who may have been on the call or listening or who might listen to the playback is that as you go through these steps on your path to be a doctor, whether you're at an HBCU, it might be less intense if you're at an HBCU from the sense that you may not feel as isolated. But if you're at a PWI, I want to definitely encourage you to not only keep pushing, but to seek cultural nourishment. So for me, I went to PWIs and things that were vital with my progress, with making it each step of the way, even when I felt like quitting, was that I stayed culturally nourished. So that was, you know, the Black Student Association. In med school, it was the Black and Latino Student Organization. It was SNMA. It was, you know, Office of Student Minority Affairs. And so I absolutely want to encourage Naima and everyone out there who is on this path to keep pushing, because we need more than 2% if we're going to change some of those racial and ethnic disparities that we're seeing. So thank you again for the panel.
Thank you. Then next we have Dr. Nelson.
I went.
Oh, okay. Then next we have next we have Miss Chofor.
It's Chofor, but thank you, Dr. Ighodaro. Thank you so much for giving me the opportunity to join this group of esteemed and well-experienced OBGYNs that I hope to call my colleagues in the future. I really appreciated this conversation. I appreciated being able to contribute to it. One thing that I do want to leave is to encourage people to look for a provider that listens to you, right? It doesn't matter. It doesn't have to be an OBGYN. All your providers, your PCP, your dermatologist, your neurologist, and they don't necessarily have to be Black, right? Being Black, it means that they are more likely to empathize with you and they're more likely to listen to you. But if you find any provider that listens to you and takes your concerns seriously, then that's who you want to be with.
Thank you. Thank you so much. Mr. Nathan.
Awesome. One, thank you for allowing me on this panel. So much wealth of knowledge, so much Black girl magic. I love it. You know, so my daughter's gonna continue looking up to you guys as well. Three things. You know, I'm big with quotes. First quote is "Squeaky wheel gets the oil," and that's just the importance of just advocation. Just knowing that, you know, that's the best way to be able to get what's needed. Be that squeaky wheel. Next one is nothing's impossible. It's just not figured out yet. A lot of times we feel that are back against the wall and then nothing can change, but we just have to understand that it's just not figured out at this moment. We can always come back to it and get this figured out. And last but not least, I always end off with making sure you invest in your mental wealth, any and everybody. Mental health is so important. I implore everybody to look into that and continue not to forget that. Thank you so much, and talk to you guys soon.
Thank you. Thank you so much. So now we are going to close, and I'll be sharing a screen with everyone. Today, we have heard many experiences, personal experience, and we've heard many experiences and statistics. We've talked about the etiologies of these racial inequalities, and we've also discussed numerous solutions. We've talked about public awareness, educating and empowering patients, providers, community, politicians, and government. We have to hold medical institutions accountable. And together we can do that. And I want to thank our esteemed panelists who have volunteered their time out of their extremely busy schedules, some on short notice, to come to this panel discussion to help empower you and empower the community. I also want to thank numerous individuals, and I will name some of those individuals right now. I would like to thank Christopher Henry, Dr. Adesuwa Akhetuamhen, Dr. Erica Littlejohn, and Dr. Taxa Cash. I would also like to thank my technical support, Edoghogo Ighodaro, Lillian Li, and Jenny Lee. I would also like to thank my family member, my mom, Stella Ighodaro, and my sister, Omisa Ighodaro. I would also like to thank other doctors who really PR'd this panel discussion. Dr. Hayes, Dr. Bagra, Dr. Lyle Jones, and Dr. Elizabeth Kuhn. I also want to thank you, the panelists, the participants, and the audience members for tuning in and for listening and for wanting to move the needle forward in saving the lives of our Black mothers. We have to continue these conversations. We have to speak truth and speak their voices. These incidences can no longer go muted or go unheard. And that's the purpose of this panel discussion and this panel series that was inspired for me by Dr. Susan Moore. I want to continue to say her name and the names of other patients who go through what she goes through on a day-to-day basis, because this is a pandemic and it has to change, and it will change. And we have to be the ones to change it. So I would like to thank you. I would like for you to, in order to continue to follow this content and to follow upcoming panel discussions, be sure to subscribe to the YouTube channel, Twitter, Instagram, Facebook, and you can see my social media handles on this screen. Also, if you would like to be added to the listserv so that you can get the Zoom registration and be part of the Zoom audience, be sure to email me on the on the screen that you see. And our next panel discussion is going to be on racial inequalities with COVID-19. So I hope to see you all there. It's going to be a very exciting conversation, and we have some phenomenal panelists already lined up. And with that, we will end today's conversation. This is not the end, but the beginning of a movement in medicine that will start saving Black lives. Thank you.
Wonderful.